Hi again. Welcome back, Sue. And if you can put your microphone on, and Simon, if you can do the same. I think it'll be easy if we just leave the mics on. And we should start with questions. I can see that we got quite a few new questions. We still got about 200 people on board, and people have been voting on different questions. So look, let's use this half an hour that we've got, 35 minutes. And the first questions that we have is from Claudia Tons. How can we get community sport on board with the idea of equity? In reality, we still often struggle to link young refugees to community sports clubs because of multiple barriers, such as costs for memberships, lack of parental ability to be involved in the club, and competitiveness. Simon?
Yeah, it's a good question. There's not going to be a short answer to this, unfortunately, and it's going to be multifactorial. I think that the first thing is identifying what are the barriers for that exact community. If it is cost, then so be it. But looking at what are the barriers and then what needs to be done. I think what's really interesting at the moment is that at a sort of government level, you've got the sort of the sporting organizations doing things like voucher programs, for example, in terms of active kids. And then you've got mental health world doing stuff around, well, we might need to promote physical activity, but there's no cross communication between them at all. And actually one strategy could actually help both. So I think the first thing is that we need people within the sporting sectors aware of mental health and aware of these populations and the unique needs. On the other side, we need to make sure that the mental health sector and services like STARTS are aware of, well, how is our role in promoting physical activity and what can we do? I don't know if that sort of answers the question, but I think the first step is awareness. The second step would be training. And then the third step would be looking at the specific unique barriers to the community that you're working with.
Thank you, Simon. And certainly, it's probably an area where we all have a lot of work ahead of ourselves, and a lot of work associated with making sure that, that more people working in the mental health area also know about, the importance. And I suppose this is a small step that we're contributing today to that end. Thank you. I got another one for you next, which is, it is good to, just from Joshua Hall, and it reads, it is good to hear that most types of exercise will be beneficial. Is it the case that even low intensity exercise is beneficial, but higher intensity exercise is more beneficial? Do your interventions focus on increasing intensity or focus, or on increasing duration time per week?
Yeah, Josh, I mean, it's a great question. The first answer is yes, the evidence tells us that the intensity does not matter as much as the overall volume or minutes of physical activity. But this is going to vary based on populations, and things will take into account, such as previous exercise history. That's going to be a factor as well about the level of intensity that people need. So if we're talking about a really unwell population who are really sedentary, deconditioned, not doing anything, getting them out of bed in an inpatient unit and doing a lap at the hospital might be enough for that person. But someone who's functioning in the community, but with moderate symptoms, but they're still getting about and doing things, are going to need a higher level intensity intervention. So it's sort of difficult to answer. What I would say is think about exercise as a stress on the body. That's all it is. And your body adapts to that stress as it gets stronger and as it gets fitter. And as that happens, we then need to change the stress to either make it more intense or increase the duration by increasing the minutes. So there's different ways that we can do that. One of the interesting things that we often get asked about is high intensity interval training, which gets spoken about a lot. The reason, and that for people that don't know, it's called HIIT training. And the idea is that you do really short bouts of high intensity work. So it could be, 10 seconds of a sprint and then 1 minute steady state or whatever it is. And yes, there is evidence physiologically that sort of activity has a greater impact on physiological adaptation. But the critical thing about exercise is enjoyment, particularly when we talk about the mental health benefits. So if we, it doesn't matter if I have this ideal exercise program that tells you have to do, exactly this minutes and this intensity, people won't do it if they don't enjoy it. So we absolutely have to be focusing on the enjoyment and the engagement, on the support, more so than the minutes or the intensity. But yes, to summarize all of that, the type of activity is not that important. The intensity is not necessarily important. It's about finding something we enjoy, people can stick to, and then looking at how do we engage and go from there.
Thank you, Simon. Next question comes from Gisela Lafico and is addressed to Sue. And it reads, it seems to me that the label refugees can in itself be stigmatizing and, despite positive attitudes, could be perceived as a barrier for the refugees themselves to feel part of the community. There seems to be still a them and us discourse as opposed to real integration. Has this been observed in Amida or elsewhere? And what are your thoughts on the terminology itself as a limiting factor for acculturation?
It's a really interesting question because essentially it's about categorization. So for people to have an attitude to a group, they need to recognize that the group is there, which is what we get through this label of refugees. So I agree with you that it does create an us and them, but at the same time, for a group to receive assistance, for example, they need that label. For them to receive positive or negative attitudes, there needs to be that label there. And also, I'm not sure that at the outset you would be able to prevent such a label from being applied. However, I was thinking about this question in terms of personal experience about refugees, and also from oh, sorry, I lost my thought. But anyway, what I was thinking about personal experience. Oh, yes, that was my thought, was also about some responses to the questions about refugees, because we do have questions in our survey that say things like, what have your experiences with refugees been? Have you ever had experiences with refugees? And a lot of people have answered with things like, well, I wouldn't know if someone's a refugee or not. So often the label actually isn't there. Like when you interact with someone, how would you know that they're a refugee unless they actually disclose that to you, or unless it's in a context where it becomes apparent. And I was also, as I mentioned, thinking about my own experiences. And, you know, I have friends who came to Australia originally as refugees, but that would never, ever have been part of my perception of that person because, you know, I knew them in a different context and it just wasn't part. So I guess that's when integration has truly occurred, is that the label is no longer relevant, even though it can be applied. So I think there's a lot of pros and cons. And I think if the label remains indefinitely, I agree it could create a us and them. But I think as integration truly occurs, the label ceases to be relevant and that us and them discourse disappears.
Thank you, Sue. And that's a great answer to something that, you know, I think we've been debating since the beginning of services, not just, you know, with the label of refugees, but labels such as, you know, victims versus survivors in terms, and there is usually a flow and the necessary stages as well. So thank you very much. Our next question comes from Bipin, and it reads, it's more a comment, but a comment that invites a comment. And it's addressed to you, Simon, and it reads, would be good to know about learning from or integrating Western models with indigenous local systems of physical and mental health well-being.
It's a great point. I mean, the thing that comes to my mind is thinking about, you know, indigenous games and things that are done. I mean, even with the young girls we worked with in Bangladesh, they would tell us stories about, you know, they used to do a lot of dancing back home in Myanmar, and that was what they enjoyed, and that's what they wanted. So I think we absolutely have to take that into account and to work within that. Yeah, so I mean, look, I totally agree. I'm not sure I can add much more onto that, except by saying that I think we also need to use that to challenge some of the gender issues that are there, that sort of present as some of the barriers to physical activity. You know, one of the things that we're really interested in is what can we do in women-friendly spaces, for example, because we know that it's one of the most acceptable things that people want to do. There are just some of those barriers. So yeah, I don't know if I can add anything to that, but I think it's a critical point that we absolutely need to consider.
Thank you, Simon. Another one to you. Again, that's from Joshua Hall as well. And it reads, I'm thinking about how experiential learning is the most effective learning. What beliefs do you think exercise has the most potential to shift? The impact on depression makes sense in this regard, but I wonder about potential to promote coping confidence, especially for clients experiencing post-traumatic stress symptoms that often make them feel unsafe in their own body, that their mind body is broken forever, or that they are going crazy, mad, etc.
Yeah, there's a lot in that. That I just think about Bessel van der Kolk's book, The Body Keeps the Score, which was one of the first, texts in this area to actually make that link between mind and body. Where to start? Look, I think it depends on the person we're working with. And what I would say is that what's interesting about exercise is that it is transcultural. It's also transdiagnostic. And I know that's a bit of a buzzword at the moment, but really the approach that you would take, whether it's someone experiencing, extreme anxiety, or whether it's a trauma, or whether it's depression, it's really just about engagement, rapport, and then finding some form of movement that that person can relate to and that they're happy to do. So I think when we talk about the mechanisms and what's driving this, and whether it's a form of exposure to those sensations that mimic anxiety that exercise can do, or whether it's distraction from rumination, or whether it's simply just getting someone more socially engaged with their community, I think there's a range of targets that we can hit with physical activity and with exercise. Part of it is about being aware of what we're actually doing, and that's why we need the exercise and the mental health professionals working together to actually enhance that and make sure that we deliver the most powerful intervention. Again, I think not directly answering this, I don't think, but I think those ideas about the physical sensations, getting people more in touch with their body, is a big part of what we're actually trying to achieve. And I think where we're seeing is the link between the mindfulness-based stress reduction, people drawing on aspects of that, drawing on aspects of resistance training, aspects of yoga to develop sort of new models that we see. But it's just another tool in a therapist or a professional's tool belt to use exercise as a strategy.
Thank you, Simon. We back to Sue with the next one. And the question from Amy Lutzwitz reads, have any steps been made to share the results with the ECD community, including the comments about positive attitudes and appreciation of positive contributions to the wider community?
Yeah, this is an interesting question because our research is ongoing. So we're continuing to conduct these surveys over a few more years yet. And so it's a delicate balance. Like if we publicise our results, it then influences the community and makes our research of less value. We won't know if part of what we get in our future results is because we communicated our results. At the same time, we don't want them to be secret, especially when they're such good news results. I mean, I'm obviously sharing them today, for example. There's also been a bit of media coverage of the results as well. Like there was an article in the Australian Weekend magazine a few weeks ago in which they mentioned what we'd found. So in that respect, the results are out there. We've given presentations in Armidale that Yazidi representatives were invited to. And so they have been shared in that respect, but we haven't done a presentation where we've invited the community together and then presented those results to them. And it's partly because also it would make the Yazidis feel self-conscious and like they were sort of this target of study. And I'm not sure that that's a very good thing either. So we've tended to do it in a more low-key way, I guess is what I'm saying. Like the results have been communicated with plenty of people who can communicate them on. The events where Yazidi representatives came along, I think they had a bit of trouble in comprehending exactly what the results were showing because, language barrier and so forth at the moment. We did have an interpreter there for one of them, but I think the interpreter had trouble interpreting it as well. So some steps have been made, but we're not making a big fuss about it. Let's put it that way.
Thank you, Sue. And yes, it's an interesting conundrum, in particular from a research point of view. but also in terms of the community. We dealt with some of those struggles with interpreting and the level of interpreting that is available to some of our newer communities. Next question, we back to you, Simon, and is from Jamal Dagwati, and it reads: is there any research comparing reduction in trauma symptoms in exercise-only group versus psychoeducation plus exercise?
Yeah, it's a great question. There is. It's not necessarily high quality research. I have a lot of problems with research that compares, that tries to compare, for example, exercise versus medication for depression. I think that's a really dangerous and almost unnecessary line to be taking for a couple of reasons. One, we need that for the basic science point of view. If we need to understand the mechanisms, I understand why we need those controlled studies, but from an implementation perspective, it's hard to imagine, and we don't want to send the message or the stigma that people don't need medication or they don't need therapy, they just need push-ups and they're going to be fine. That's absolutely not the message we're sending. And I think it's really important that we sometimes the media goes too far the other way, and that they love talking about this stuff and they love writing articles saying go for a walk, it'll cure every disease under the sun. But that's often quite alienating, and particularly with mental illness, people that are really struggling, if they're at home reading this article that implies that all they need to do is get off the couch and they're going to feel better. So I think it's really important that we don't sort of have those comparisons and we don't talk about, exercise instead of treatment. It's an adjunct. We do them together. It's really hard to see in an environment, a clinical environment, why you wouldn't offer both if required. We know the evidence tells us that in mild to moderate conditions, so mild to moderate depression, anxiety, these are particularly Canadian guidelines with the most progressive. They will advocate that exercise should be a standalone first-line treatment for mild to moderate, but that's it. And so really, I think what we should be talking about is, right, no matter where someone is on that spectrum, how do we add exercise to their treatment? Not do we replace other things. Again, for mild to moderate, we see cases and there's data around people reducing medication load and all that stuff. But again, I'm really apprehensive to talk about that too much, because I think that's not the messaging that we should be going down. The same thing is to be said for different types of exercise. I'm not sure we need research comparing aerobic versus resistance versus blah, 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 because actually what the evidence tells us is we need to offer all of those things to the right individual to match their needs with what we can deliver. If someone wants to do strength training, great, let's have that available. If they want to do yoga, excellent, let's do that. But how do we match the needs of the person?
Thank you, Simon. And yes, it's always, our approach, as most torture and trauma services in Australia take that approach of a biopsychosocial model that integrates different kinds of interventions, and very much a horses for courses approach. But of course, that's always harder to build an evidence base for. And of course, pathway studies are very expensive and lengthy to implement. But thanks for your insight. It really supports, I think, what most of us are doing, but it raises the issue of the challenges that we have to ensure that there's adequate funding for, the kind of approaches that incorporate these physical activities and so on.
On that note, one of the interesting things we've done here at Southeast Sydney Local Health District, because we got about $1 million of recurrent funding to roll out what we call the Keeping the Body in Mind team. Mm-hmm. And those teams are an exercise physiologist, a dietitian, a clinical nurse consultant, and a peer consumer or peer support worker. And those teams are providing lifestyle interventions to consumers in the mental health service here in Southeast Sydney. But before we rolled that out, we actually offer the exact same intervention to the staff of the mental health service. And we've published that this year in the Journal of Health Promotion, Journal of Australia. But the key point there was showing that actually, if we want to change the culture of mental health services to actually really agree and to support the implementation of these interventions, we actually need to start with the staff themselves. They need to understand what they're doing, how it's being done, and really the purpose and the drivers behind that. And then we get better outcomes with the patients afterwards.
Thank you again. Sue, back to you now. From Natasha Harding. Thank you for the great presentation, Simon and Sue. Sue, was there any indication that community attitudes were influenced by external things such as media, politics, TV shows, etc., or was the research more focused on local impacts of connections in the community?
So our survey didn't ask a question about influences such as media and so forth. So we wouldn't have a measure of that. What I would have is what people said in their open-ended responses. We did have a measure, by the way, of the effects of contact with refugees, but I think that's a bit different to what you mean, because you're talking about impacts of connections in the community. In the open-ended responses, there was no mention anywhere of newspaper articles or TV or anything like that, whereas there was a bit of mention of what other people had said. So especially in survey 4, you know how I said that sometimes people made mention of things like, oh, they're nice people, they're lovely people, they want to work, these sorts of comments about them. Some of them were saying, I've heard that, and so they must have been hearing it from other people. And I'd say also my impressions as a community member in Armidale would be the same. I mean, people talk with each other a lot, and especially a development such as a refugee resettlement within Armidale, that's, as you could see by the level of uptake of doing those telephone surveys, you know, 91% of people wanted to do that survey. So there's a high level of interest, and I think it's about the discourse within the community rather than what they're seeing from media and so forth.
Thank you, Sue. And of course, the longitudinal part of your study is happening, you know, while this massive thing of the pandemic is also influencing things. It'll be great to have you back, you know, to discuss that longitudinal aspect in time. Mm-hmm.
So we're doing another survey next month, and we hope to have questions in there about how people feel about the epidemic, and then we can correlate that with any changes in attitudes to the refugees. However, I've got to say I'm having a battle with our ethics committee at UNE who don't want us to include those questions. Mm-hmm. So the survey might be delayed until I can get a yes to that one.
Yes, no, I can imagine. And so I got another question from you. It comes from CUPA's training team, and it reads: if there is a small number with loud voices in the community and negative experiences that could be reported in the media can have a strong impact on community attitudes, how do you suggest this is responded to?
Yeah, this is a really good point, and something that SSI have been aware of since the beginning of the refugee resettlement program. So SSI, the settlement agency involved. Really, it has been managed in Armidale by getting the media on side. So right from the beginning, there was engagement with the media to get quite positive stories out there, and especially stories about individual people who were arriving in Armidale, sort of telling their story and trying to make it quite personal. The local media, like, we don't have the free newspaper anymore at the moment because of the epidemic and all the impacts on print media. I think there's a paid newspaper, which I actually don't subscribe to, so I haven't seen what's in there. But I do know that at the start, it was a specific strategy to get media on side.
Thank you. Thank you, Sue. Our next question is for Simon, and it reads, is there any research around best exercises for refugees with physical disabilities or barriers to walking or running?
The short answer is no, but what I would say is there's a increased attention on this because there is a field, for example, physiotherapists, exercise physiologists, that's their job. They're trained in providing exercise programs for people with you know, complex or chronic conditions and in need. So, you know, example in Bangladesh, humanity and inclusion, they're actually employing sport for, you know, sport, I can't remember what they're calling, sport for inclusion officers, I think it is. And that will essentially be their job. So it's an emerging area. We have the knowledge and skills, it's actually just applying it to people working in these contexts. So I think, you know, in the future, we're going to see you know, far more people with relevant experience applying that, because it's just applying knowledge from other fields to this area.
Thank you, Simon. I forgot to mention that question came from Jamal Darulati. Our next question is from Vina O'Sullivan, and it reads, any movement is better than no movement. Exercise prescription in any population needs to be done with care, and progression of exercise has to take into account physical limitations, pain, pathology, etc., as well as mental health factors, how to motivate, and so forth. In my work, and Vina is one of our physiotherapists at STARTS, I have to consider what I'm trying to achieve through exercise. The targets, my prescriptions, as it were, building on strengths, rather than focusing on weakness, if that makes sense. So I suppose she's asking for a comment on that statement.
I agree entirely. We think about what are the aims, what are we trying to do? If we're trying to, if I was working with a veteran, for example, who, or an emergency service worker who needs a certain level of intensity, a certain level of stimulation, depending on their context, it's very different from an older adult who potentially, is got mobility issues, and, it's very different. So we have to target that accordingly. One thing that comes to my mind there, though, is the misconception around exercise, and particularly linking to weight loss. I think that's a really critical mistake that a lot of services make, where we and people, because the general messaging in the community is, if you ask people the number one reason why they want to commence exercising, it's weight loss. But the evidence we have is very clear that exercise is ineffective for weight loss. If our goal is weight loss, we need to address the diet as a priority. But we have this disconnect, because if people are wanting to exercise for weight loss and then it's not effective, there's issues. So we need to re-educate and refocus. We need people exercising because they say it helps me manage my mood, I feel better, I sleep better, I function better, as opposed to the weight argument. But otherwise, I agree with everything Dina said.
Thank you, Simon. The next question, and we got now 9 minutes to go and about 16 open questions still. Clearly, this has been a very popular topic. And so we're going to try and go as fast as possible. The next question is actually addressed to both of you. And it's from Alex Caldwell. And it reads, do you have any suggestions as to how best to reduce the 17-year gap between research and implementation?
Yeah, Sue, I could jump in quickly here first. For me, I've just sent a link there to one of the papers that we've done. We've really focused on training the staff. So taking a step back and looking at, taking an implementation science approach, looking at what are the unique contexts in each environment that you're trying to affect change. It takes time. Being aware that, mental health services have, functioned the way they have for a long period of time. It's going to take a lot of time to break down those silos, but we need to start with, I think, the champions, identify the champions, focus on the training. I think that's one way we can actually speed up the implementation side of things. But definitely drawing on implementation science, there's a whole body of work there. There's tools, there's technique, there's methodologies that can assist.
Thank you. And Sue, perhaps your area is even more challenging, because first we need to identify what are the implications for actual changes in practice, from your research.
Yeah, it's a very interesting question, because I guess as we do this very applied research, we've been feeding the results through to the agencies all the way along from the start, and also to government bodies. So we're trying to get the implementation happening straight away. But then the theory side of it, because this is going to have an impact on theories as well, the theory side of it will be much slower, and also to replicate and see if the results are found in other communities and so forth. The research itself is going to take a long time. Like, I've been doing this now for 2018, 19 and 20, that's 3 years. I'd say we need about another 5 years really to see how things pan out in Armidale. And we'd like to see other communities as well. Someone was asking about Newcastle, for example, but we've only got Armidale data. So just the process of doing the research, let alone communicating it, is a lengthy thing. I think communicating it as we go along is the best we can do.
Thank you, Sue. We'll move over quickly to the next question. It comes from the CEO of TFSS, and it's addressed to you, Sue. Do you think they were or are the appropriate skilled services in Armidale to deal with a high level of torture and trauma? Are they looked at before locations are identified?
Yeah, that's a good question too. I know that part of the reason Armidale was identified as a refugee resettlement site was because we already had quite a lot of capacity, and we also, they thought we'd be able to bring people to the community. So once the refugee resettlement started, there were a number of appointments to people in Armidale. So we did expand the capacity and then starts. I don't think you already had an office, did you? You opened an office in Armidale at that time. Yeah, so in
soon
that
after, and for us, the challenge was that we needed to start taking people there before we could hire local staff or have staff move there, as it was the case to begin with, and develop an office. Yeah.
Yeah, so I think the capacity tends to follow the people arriving, but you would have seen in my slide about the concerns. Community has been expressing concerns about services all along, and I think for regional resettlement of refugees, it's a very important issue, and it's in a way wrong that the services followed to Armidale. They should have been there before the refugees got there. And, you know, the Yazidis have gone through terrible, terrible stuff. And so it would have been great if there could have been more in place before they arrived.
Thank you, Sue. I may add to that this is a question that we've taken up with, you know, the federal level ongoingly, because certainly the what we find in regional areas is that the needs are often compounded by lack of other services, which means that often we, you know, the services we have to provide, you know, have to, you know, cover, you know, a wider scope. But also in the case of communities such as Armidale, you know, the refugees arriving there went from a community that probably, and I met with this community, with the Yazidi community many times, you know, has been from, as you were saying, from horrendous circumstances. So there was a double whammy of a very a community that has been extraordinarily impacted by trauma, and that trauma is still going on because many of the families are still in situations in Iraq and Syria of you know, ongoing danger and privation, and so it's it's been an ongoing challenge. Let's move on to the next one, and the next one comes from Dominic, and it's addressed to you as well, Sue, and it reads: how have the local First Nations and Yuan people in Armidale experienced the influx of Yazidi people?
Yeah, this is a very good question too. So in my surveys, I have actually identified whether people are First Nations or not, and I've tried to look at differences in responding to the Yazidis across First Nations versus other members of the community, and I've found no difference. But on a more individual level, I know, for example, that one of the local elders very quickly made a connection with a sort of, well, can I use the word leader of the Yazidi community? I don't know. But anyway, he made a connection with members of the Yazidi community, actually based on their shared trauma very early on, and they built a connection in that way. I don't have any evidence about the broader community being more involved or anything like that, like the broader Indigenous community being more involved, but I do know that good steps have been made.
Thank you, Sue. Next question from Shakemo Martin to you, Simon, reads: thank you for your interesting presentation. You mentioned that benefits of exercise were apparent in every situation and context. Could you please elaborate or direct me to more reading? I'm interested to see if context made or could have made a difference, such as deterioration of circumstances, raw hardship, a worsening of situation, further outbreaks of war, etc.
Yeah, it absolutely makes a difference. I think I might have just typed an answer. It absolutely makes a difference, but I think the key issue is about just having the recognition that physical activity and sport is an evidenced MHPSS strategy will then change the way we approach those situations. So regardless of the level of crisis, you know, kids need an outlet and they need to play sport, and there's no point, you know, we talk about shelter and we talk about all those hierarchy of needs, but if we lack meaning and we lack anything to do, then there's not much, you know, it can be very difficult for people, and that can be a big source of distress. So I think it's about changing the way that we conceptualize and the way that we think of sport and physical activity, because it's interesting. Even in Bangladesh, I was working with IOM for a while with the MHPSS team. About 30% of everything our team did when I looked at the data was organised sport in the camps. But yet, as the MHPSS team, they never discussed that. It was never really anything they had training in, but it was just something they naturally did because with limited resources, it was something they knew could work. And so I think that's really interesting. But why, what other jobs do we have? Well, possibly a lot, but where a big chunk of what we do, we've had no training in actually doing. So I think that's probably the opportunity. It's about, working with those contexts as best we can.
Thank you, Simon. And the very last question addressed to you, Sue. It would be good to know reasons why people were resistant and concerned about new refugees in the community and why it increased over time too. I know it's a very long question, but if you could, you could have a very long answer. If you could answer that briefly, that would be terrific.
Okay, great. Well, thanks very much for this question. Firstly, I just want to clarify something. The number of people in the resistant and concerned groups greatly decreased over time. So it's not an increase over time. We did demographic profiling of each of the groups, and the people in the concerned group tended to be people who were worried about threats to their jobs. People in the resistant group who were more negative tended to be people who were very, very long established Armidalians who were also quite resistant to other cultures coming into the town at all. So it was really, I'd call them people who are very focused on white Australian culture and don't want to see any change to their beloved community in exactly the way it is. So they wanted to preserve things as they were.
Thank you, Sue. And you managed to address that very. I know that I've discussed with you before, and I know we have very long and interesting discussions about it. Look, thank you both so much, Simon and Sue. This has been absolutely terrific. Your presentations were both, illuminated in terms of presenting new things and really interesting as we can see the number of questions and 200 people staying during this discussion. And thank you for participating and addressing all these questions. Thank you also for all of you that participated in this webinar. It's been great to have your participation and hope that, we've answered more than 21 questions. And thank you for participating in what's been, I think, a terrific morning.